Welcome to the next episode of the LIT Show. The LIT Show is a show organized by Dr. Raut's Center for Reproductive Immunology, which is a specialized center in Mumbai, India, which treats patients with repeated pregnancy loss, IVF failures, and unexplained infertility with the help of reproductive immunology, especially lymphocyte immunization therapy and other passive immunomodulating treatments. The LIT show involves the interaction with various gynecologists, IVF specialists, and infertility specialists, and also patients who have been benefited from the use of reproductive immunology at Dr. Raut's Center for Reproductive Immunology. So the purpose of the program is also to share the experiences of these experts and also of the patients. Today we have a very young and dynamic doctor with us, Dr. Sheetal Pandey, Tejwani. Welcome, Dr. Sheetal.
Thank you, ma'am. Thanks a lot for inviting. It's an absolute pleasure to be here with you.
So let me give a brief introduction of Dr. Sheetal Pandey. Dr. Sheetal Pandey has done her MBBS, MS, and her DNB in obstetrics and gynecology, and also she is a fellow in reproductive medicine. She is the director of fertility and the IVF unit at Veda Fertility and Urology Care at Mira. Dr. Sheetal Pandey has done her MS in obstetrics and gynecology from the prestigious BJ Medical College, Pune. And she has done her DNB from the Diplomat National Board, Delhi. She's taking her training in fertility and IVF from Dr. Namita Kota at Astha Fertility Center, Jaipur, Dr. Purnima Nadkarni at Kila Pardi, and Dr. Rama Raju at Krishna IVF, Vizag. So welcome again, once again, Dr. Sheetal. We'll start with the LIT show.
Yes, ma'am.
So thank you, Dr. Sheetal, for here with us in the LIT show. So let us begin. The first thing we would like to know is something more about you. So can you tell more about yourselves, about your education, and where are you from?
Yes, sir. I personally belong to Mumbai itself. I am born and brought up in Mumbai. And then, as you already informed about me, that I've done my MS in obstetrics and gynecology from BJMC Pune. From the year it became Nashik University, it has become MS rather than MD.
Okay.
And then post-marriage, I was shifted to Jaipur where my husband was doing MCH urology. So there I got the opportunity to work with an IVF center, which I have mentioned as my mentor, my first mentor, Dr. Namita Kotia. There the journey of learning IVF started. I worked under madam for around 2 years in an IVF center, which gave me all the basics, absolute basics were put in at that time. And which absolutely, I really got interest in fertility and IVF, looking at the treatment protocols and the results and the way patients used to be suffering with infertility. And when you give the result, that the kind of satisfaction you get inside made me follow IVF and leaving behind obstetrics actually. Even that was really dear to me, but then couldn't manage with both practices. So shifted completely to fertility and IVF to brush up more onto the subject. I then followed late respected Nadkarni madam, and then even with Dr. Rama Raju sir, Krishna IVF, which is Visakhapatnam. It was absolute pleasure to work at Visakhapatnam. That is, sir is really a research level personality. So it was really nice time being there also. So this way, completely I went into IVF. And the day I felt I can pay justice to patient and the field, I started doing my own and started with my center.
Why do you selected IVF and other than say general infertility practice? Why IVF? Can you tell more about that?
Yes, sir. So general infertility practice, most of the gynecologists are doing, like basic infertility, they are taking care of. But alone, sir, with the obstetrics, practicing general infertility, we are unable to focus. That is what is my belief is. We are unable to, take care of the every parameter of the female and the male partner, thinking of for that particular case, and then going in right direction. Because fertility and IVF consultant, I would label myself as not only as IVF consultant, because if I have a specific case, say for example PCOS, endometriosis, whatever, if I'm able to work on that patient's, ground level issues, many a lot of times we are able to give them conception in less than IVF. Natural cycles do work. IUIs do, definitely IUIs are not having out of the way results, but you still get results if you manage the case meticulously. And that becomes difficult if we are thinking of general infertility practice. Then we have to practice ops. Alone that will not let us earn the needed amount of bread and butter. So that made me focus. Let's do one thing and let's do it precisely. And then to complete the setup, definitely we know where nothing works, IVF definitely works. Yeah.
So, when you started your IVF practice, what were the challenges that you faced when you started?
Yes, ma'am. The commonest was the technical challenge. I was prepared with my education. I was knowing the stuff. I know how to do the pickups and all that. But then you need the center. And that's a big investment for a fresher to come in the market with no background, like no medical background, per se, can say. And that was the first challenge. And I would thank Dr. Sharda Kulkarni madam and Kaustubh Kulkarni sir for the same. I did approach them that I have OPD. I can just perform up to follicle studies. I do not have a center where I can do my cases. That time they were kind enough to allow me for the same. And they took my patients as good as they were treating their own. So all the pickups and the transfers which used to happen in their guidance, I got absolutely awesome results, I would say. So that was the beginning, and that did boost my confidence. Okay, fine, I started doing IVF, though it's not my center. Getting result boosts your confidence to go further. If I did not have result at that time, maybe I would have left or got diluted with some other works as well. So their support to begin with in Mumbai was immense, and I'm really grateful for that. Over the time, I could make up the things that I can go with my own. You need funds, you need the infrastructure, you need the right amount of support. When you husband wife are of similar age, same batch, both are struggling. So it takes little incubation period to come to the base. And then once I was prepared with this baseline things, we did put our own center at Mira.
So I think it was really nice of Dr. Kulkarni to help you and give a helping hand. But I think the other side also must be true that you are also good. So therefore, they had no hesitation in allowing you to be with them or come and do your cases.
They are very precise with the protocols. They are very strict. I literally liked, sometimes if I was not precise, I used to get even little scoldings from them and really felt happy about it. That corrected, the remaining bits of mine. And maybe whatever results I get today, there is definitely contribution of sir and madam in that.
So that's the practical training, you can say.
Yes, absolutely.
So then when did you start your own center then?
I started my center way back in 2016, sir. 2016 we started. Now this is 6th running year of my IVF center.
So this is a standalone IVF center that you have.
Yes. Yes, and this is a kind of, actually this is a hospital, I would say, where I have my IVF unit on the second floor, and ground floor is dedicated to the OPD and the daycare. First floor is general OT and the routine stuff, like even the urology cases, my laparoscopy cases, which I need infertility patients, are all managed on the first floor. We have that combined kind of setup where both are practicing. Yes.
So, how do you treat patients of unexplained infertility and recurrent implantation failures?
Yes, ma'am. Unexplained infertility. So we have already done all investigations to explain it. We couldn't. So definitely, ma'am, we clearly understand as medicos that either there is a fertilization issue or there is an implantation issue. Something is coming in our way. So sometimes still, though the cervical factor has gone out of the box, still in some patient it does exist. So patients of unexplained infertility, I do give a quick trial of IUI. I do,
Okay.
I do. Yeah, looking at that hormonal profile, maybe an anti-IUI as well, using antagonist in that. Few times I'm successfully lucky. Rest other cases, we keep the counseling done previously only, that we are giving it a quick trial if the husband parameters and other things are fine, taking them for IVF, because I want to rule out that fertilization failure kind of a thing.
Ah,
Yes, ma'am. Which I found personally, that's my experience, that is the commonest problem, the fertilization failure. Where there is no fertilization, no embryo formation is happening. That's why it is not. But yes, there are few lot of cases where there is an implantation failure. So when it came to implantation failure, then I started interacting with sir regarding this, because this was one of the needed fields, not yet much explored by me. But after coordinating with sir, I started reading about it a bit, then got an idea. Okay, yes, it does has the space. So cases of sit up, cases of unexplained infertility, definitely IVF. If I feel that in an attempt or two, it's not conceiving, I expect a patient to conceive within 2 attempts, because we are going for blastocyst culture. So hopefully we are able to, unless and until there are grave parameters with any of the partners. So if we are transferring blastocyst within 2 attempts, we expect the result. So if that's not happening, I start doubting implantation, because by then I have already ruled out the cavity. After ruling out everything else, only we are going to transfer the embryos. Then we start thinking of implantation related issues. And then comes the discussion with sir, as I always call him back.
So I think one more frustrating thing in infertility practice is you have now treated the patient successfully by IVF or by IUI, and patient conceives. So there's joy. But some of these patients are not fortunate enough and they end up in miscarriage. Sometimes they have recurrent miscarriage even after succeeding with the IVF technique. So this must be really frustrating thing. So what do you do for such patients?
Yes, sir. This has been frustrating thing. When I started interacting with you, then I understood that previously we used to take it little light. Okay, fine. 5 patient may say 1 or 2 ka that thing happened. And whenever patient used to ask, to begin with, I used to feel that probably it must be an aneuploidy, because that's the commonest blame game. Yeah, but then we send the this POCs, and then we don't get any aneuploidy in that. Then we have to have an answer. Yes. So because chromosomal analysis of both the couple is fine, to explainable extent, we were at a deadlock. Then started thinking about the thing about immunotherapy and all came into my mind over the time.
so you said you interact with sir. So how did you come to know about this immunotherapy and immunomodulation?
Practically, why I'm telling sir again, because it was sir only for the first time I attended his one of the lectures.
Okay.
He was a guest speaker at Mira Road GCC. Then I had attended his lecture, and then that lecture was thorough, very much in detail, covering every bit of it. So I could understand there are many things we have not yet explored. So then it came into the picture. But yes, sir, now I definitely feel those patients, even in IVF, getting missed abortions or even biochemical pregnancies. Yes, when they ask us, you to said that embryos were too good. Definitely, we are seeing morphology. We are not able to say genetics, but aneuploidy cannot be the always blamed. We have to think beyond it.
Yeah, what you're saying is absolutely right. I think reproductive immunology should be considered, and still we don't know many things in reproductive immunology. But whatever we know, or to some extent whatever we feel we know, if we can use for the benefit of patients, then I think to at least some patients we can help to overcome this problem of either infertility or sometimes even failures after even successfully treating infertility, but not continuing the pregnancy.
Take home baby.
Take home baby. Yeah. Exactly, because that is what is finally important for patient, and I think we also should consider that rather than just being happy about the conception rate or pregnancy rate.
I believe the investigation profile should add up few tests coming.
Yeah.
Because if in advance, we get to know some idea about it. Yes. Why to waste those cycles, because they are pretty costly for patient also.
Correct.
Some patients may not be able to afford it later and they might just quit. That's the bother.
Yes, yes.
Yeah, we have seen some of your patients. I think a few which you have, some of them which you have referred either with I think IVF failure or miscarriages. Can you share their experiences, or what is your experience about those patients who then required immunomodulation or who have undergone lymphocyte therapy at our center? Can you
Yes.
share a few cases?
Yes, sir. So the commonest case, the one which made me really think about it and keep advising to other patients and even other gynecs, when we discuss out, I do speak about this thing. There was one case where I was doing IV. I did the pickup PCOS patient, good number of eggs I got, and we could freeze 3 loops. So 3 transfer attempts I had. So 2 times I did transfer. First time I transferred, patient carried a pregnancy up to 6 weeks, 6 to 7 weeks. Cardiac activity had come, everything was fine. Patient just had a typical heavy bleeding, and the embryo was like thrown out kind of. When we load patients so much with progesterone, we do not expect such kind of a bleeding. Patient might have little bleeding, intermittent bleeding, but just throwing out of the embryos generally doesn't happen. So that was, I didn't understand the pattern of abortion. That pattern of abortion really made me think, fine, still I was in the dark side of knowledge as far as immunotherapy is concerned. I had the other loop. After a few months, 3 to 4 months, when she was all out of it, I transferred again. Similar pattern again. Around 6 to 7 weeks, that was the time. She again had a bleeding, but it was not like spotting. She never had anything. She will be all good. She'll come for the scan. She'll take all medications, and we do frozen embryo transfer cycles for PCOS, where we are loading lady with good amount of progesterone. With heavy dosage of progesterone, embryo may not grow inside. Patient will not throw out, kind of. So again, she had a heavy bout of bleeding. That pattern again was like lots of queries on for me. Then I did interact with sir. Sir had advised, given me those list of investigations, which I had never done in any patient. Was not knowing much about it. That is the time when I met sir in his lecture at Mira Road GCC. And then I went ahead with those investigations, and sir did find that LIT can be tried in that case. Sir did do the LIT treatment, and we transferred again that within that duration when it is most effective, which as advised by you people. And then this time again she conceived. The best thing was that every time I used to transfer, she used to conceive. So that was the last loop of embryo with me. Otherwise, we were repeating the whole IVF all again, stimulating her, taking out the eggs and all that. And then I did transfer, and luckily this time also she was positive. Keeping fingers crossed, because our bother was that 7th week or nearby time. And then those all things, those intralipids and Bhaglobe, everything was going on. Luckily, the child is already 3 years. She comes to that baby comes to my clinic only for vaccination, because there is a sitting pediatrician also. So I see that child and I always remember the wonders immunotherapy can create. Because in this patient, it was absolutely same patient, same loop of embryos, same time pe nikale hue. 2 times I transferred. We always transfer the better embryos first, morphologically looking. So if I have 3 loops, I'll transfer the best one in the first attempt. Then the second best one in the second attempt. Then the third one will be like thick average one. And that average one is 3 years now. So we'll happy about it. There I got an absolute confidence over this treatment.
I'm sure, I think you said you have been sharing this with your colleagues also. And I think we have that experience, because one day we got a call from a doctor from Mira Road. And this was a patient who had multiple miscarriages before, and she was pregnant and she had bleeding, threatened abortion. And she said, can anything be done in this case? She was maybe early pregnancy, 8 weeks or something. She sent that patient in ambulance, the doctor, and she took the therapy, and subsequently patient went back and she did well. So that's what even literature has said, that even LIT during pregnancy has equally is equally effective when compared to given before, if not given before. For us, we always give before, and our protocol allows us to give only once, and that takes care of effects during pregnancy also. So nice. I think there were many more patients, and they have also done well. Can you tell me what was the experience of the patients? Was it a very cumbersome thing to undergo this process, or what was their experience?
No, it was a very quick thing to go ahead with. There used to be first investigations were done at our level. Then we used to share investigations with you. And you were very kindly available telephonically also to patients sometimes. And they had one consultation with you, sir. I think the second time the treatment happened. And it was like no multiple coming and going to the clinics. And it was very quick. It was very quick rather. First time I was like, it is done. Oh, it is done. So it's not cumbersome for sure. The way IVF is super cumbersome treatment because patients are seen every day to the clinic, every day. And it was hardly, I believe, my patient had 2 visits to you, and the treatment was also done in that.
No, IVF doctors are doing real great job. We are not doing IVF in our center. We just do the reproductive immunology treatment. Patients are referred to us by different IVF centers, and they go back for IVF to respective centers. And yes, we have been able to help many patients like this, the way you shared. So, what do you think about reproductive immunology now? As what were your personal experience? See, in our curriculum, we were never taught about reproductive immunology. So even our post-graduation, hardly any mention has been there. So what do you think now about, and do you think it has a greater role to play in future?
Definitely, sir, definitely. As we previously also discussed that implantation and then growth of the pregnancy. So not that every patient would require, but definitely a certain chunk of patients would require. So that is why I thought reproductive immunology means definitely we are talking of those patients who are struggling for conception. And once we are able to make them conceive, we do not want that conception to just go away. We want that baby go home. Yes. So I believe that definitely it has got great role in deciding implantation, especially in those patients where the immuno function has been affected. I think, let me put it this way, the acceptability of the uterus or the endometrial receptivity, as far as immunorejection is happening, rather should be the correct word, is happening. In those patients, it will definitely help. That's why I feel like we should start putting those investigations also in the routine. So we understand that there is no immunorejection that is happening, so we can take care of it earlier. And once implantation has happened, if there is a chance of it not going any further, like when frequently biochemicals happen, and when we think that the good quality embryo it was, aneuploidy is always at back of our mind, but that cannot be always the blame. Secondly, and thirdly, very well that you mentioned, now I understood that in pregnancy, when the lady had bleed and it was given, and probably that must be the only thing which was extra done this time, and it worked. So this is how I give take home message to myself as at these investigations at the first go. And if there is any doubt about those investigation, any reports, then can coordinate with sir and madam. And so we can actually figure out those cases, we can survive the pregnancies rather than they getting aborted. Because they are precious.
Yeah, one thing Dr. Sheetal you said is very important is that you add these investigations to all the other investigations which you're doing. Because many times all these factors could coexist also. So if you want to give a best outcome to the patient, as you say, and you find out that yeah, immune rejection is also there, you can treat it simultaneously rather than the patient waiting for 1 or 2 failures and then you treat immune rejection. So we can work always hand in hand at a very early stage rather than, waiting. And as like you rightly said, patient spends a lot of money, a lot of precious years. So this is a very important point that you put forth, that we put all the investigations together so we can diagnose and treat it together.
Yes. Because the cost burden that it will put to the patient, if you think about the total amount of money a patient has to spend for a fertility cycle, for an IVF cycle, if we think about those investigations, then in comparison, that amount is meager. Comparatively, IVF cycle amount, I meant to say. So there is where we can survive. Yeah.
Right. So we, as you said, there are a lot of challenges in IVF practice. I think there is one more challenge which has come up recently, is the new law, the IVF and surrogacy law. So what do you think about it now that we discussed about what you have been doing. What do you think about the law and how will it change the practice? Means, do you think it will impact the practice of IVF centers, and what is your view?
Yes, sir. It will definitely impact the practice of IVF centers because you have lost that autonomy. For surrogacy, I do not practice surrogacy and somehow I'm never interested in. But yes, those genuine patients would suffer. Genuine patients would needed surrogacy because no one will come out of humanity so easily. I hope people come out. But the way they have said that no more commercial surrogacy, only altruistic, where someone has to come out of the humanity and just help you out, the way it is there in abroad countries. But looking at the infrastructure, scenario, economic status, everything in our country, maybe those who are genuinely needy may really find it difficult. Those who are using it for fancy, I am really happy. Okay, it has been taken in regulation. And secondly, donor oocyte, yes, that's going to be a tough job because we have lot many premature ovarian failures or very, very low damage. Or though the eggs are there, but the quality is an absolute issue. I have seen 8, 10 eggs, day 3, all arrest. All of them arresting. Then we know even if I transfer her day 2, day 3, it's not going to grow inside. So those with poor quality oocyte, because the problem is going to come as the cost is going to get affected. When it will be retrieved, frozen, quarantined, will be given to us. Probably the norm as one donor going to one patient. So that demand and supply is going to get affected. Cost is going to go high. Thirdly, the protocol thing. Still, IVF is still the thing is not so easy. Ki we quickly did the embryo egg freezing and we did the thawing and we got excellent oocytes. That doesn't. Still, India is not doing very at a large scale the way we are doing embryo freezing at such large scale with such good frequency. We are not doing oocyte freezing. So when this will start, patients will pay for that oocytes. And I'm not very sure what kind of oocyte we are going to get post-thaw. So I have my own idea. Definitely government is not going to count me anywhere. But I believe if there is a bank, they want regulation. So regulation should be put in. Someone should be regulating it. But we should be given opportunity to do our own oocyte pickups, freeze with our own teams. We can have our own cryocans and outsourcing. Like our Veda will have its own cryocan. We'll pay the charges of utilizing the setup and we'll be abiding all the rules. In any one setup, we cannot break the rules. So itna the surety they will be having. So everything at rule will be going at one center. We'll have our own cryocans. We'll use our material and we'll just come off. So at least we'll be sure that the protocol exactly what I wanted. So many freezing media, so many thawing medias. One media works in one lab. Other lab and other person is happy with the other. Still, so much of choose and pick is going on in fertility, and we are happy. Like suddenly, this Lebotec ET catheter is out because Germany was in lockdown, so we are not getting it since 2 months. Though I'm getting results with the other catheter, but I'm very unhappy. I'm sad. Like when it will be back, that comfort zone. So if I get one pregnancy negative, I think it is because the catheter is not there. Because you're so accustomed to your tools, actually.
Yeah. I think this definitely will have impact, especially surrogacy, and because when the law was implemented, after that we have got quite a few phone calls from our doctor gynecologist friends that our patient is going to go for surrogacy. Now, can LIT help these patients? So we had to explain to them that if the uterus is not healthy, uterus is damaged, LIT is not going to do the magic. But yes, a lot of people are thinking now, is there any other alternative which can be used for these patients where maybe it's a reproductive immunology and multiple failures. So I think only time will tell, and once we get the clarity about the law, then I think the rules and regulations once are clear, then the picture will be, I think, clearer.
Yes, so role of LIT, I had one query in my mind. The cases of adenomyosis, I'm talking about genuinely surrogacy cases of adenomyosis, generally these are the women who go ahead with surrogacy. because their wombs are not so very much receptive. So just to put forth, like I am with my laparoscopic surgeon, Dr. Pratesh Naik sir. He is the lap surgeon at my place, and he does wonderful job, definitely. So we have done 10 cases of debulking of adenomyoma, and then working on to the uterus with certain needed medications, and have done the transfers. It may be difficult to believe, but out of 10, 7 patients have conceived. 5 have got take home baby. One patient had a twin conception, so at 20 to 24 weeks, it didn't work. But I'm talking about uterine receptivity and conception. So it was twin, so it was unfortunate. Probably, if necessary, if it was singleton or God had been kind, even that baby would have gone home if 1 or 2 months more. So, sir, I have this point. Those patients of adenomyosis, where surrogacy and all is going on, where we are not doing surrogacy and rather we are debulking and actually they are conceiving, these patients' uterine receptivity, endometrial receptivity, can it be improved with LIT?
See, I think very important question, because endometriosis. So if you take the case of endometriosis, we have a lot of patients whom we have treated or referred to us, isn't it?
Yeah.
Who have been found to be associated with immunological problem, very common. And they have endometrial cases, CD57 cells positive, which are detrimental to pregnancy. And after immunomodulation or lymphocyte therapy, these patients have done well. Many of them had IVF failures before and they have just conceived spontaneously. I think yesterday only I got a call from Nagpur from one of our doctor friends that this patient conceived naturally, and she had IVF failures, grade 3 to 4 endometriosis. So that apart, but adenomyosis has similar pathology to endometriosis. So there is always a possibility, though we haven't treated many of adenomyosis with immunomodulation, but they also will have immunological disturbances in the endometrial lining with the presence of detrimental CD57 type of cells, and that can be a mechanism which can be helpful. Immunomodulation can be helpful in these patients. And now with the changing scenario, if they are not able to undergo surrogacy, maybe yes, more of reproductive immunology can be used for these patients, and if we can help them, that will be really nice.
Actually, sir, combination of surgical debulking,
yes,
endocrinological corrections with the necessary medication, and receptivity improvement with the LIT.
Because about endometriosis, we are very sure. Very sure. We
do have an immune problem, because it is said that every woman bleeds inside during the period because the tubes are open. But patients who are prone to endometriosis, they somehow the blood retains over there, causing the endometriosis, and so majority women escape. Now these patients where the blood retains and then the immune system comes to destroy that blood, and then all the adhesions form and all. So these are the patients where they are probably going to have an immune rejection also, along with endometriosis, with positive CD57 cells in the endometrium and raised anti-thyroid antibodies also. So this is a big complex where the immune system definitely is known to help.
Yes. So I guess if I get few cases of adeno, maybe I'll coordinate with Sir and Madam.
We can always work together after debulking, and when you're giving the patient medical treatment, we can always work for the immunomodulation. And one thing we have found is that those patients who underwent immunomodulation and who underwent a cesarean afterwards with endometriosis, like grade 3 and grade 4, during the cesarean, there were no adhesions, no endometrioma seen. And it's not only in Bombay, but we have had people from Nagpur reporting, from other places, Delhi and all, reporting that when they did the cesarean, they did not find any traces of any endometrioma or anything. So one is, pregnancy itself is a treatment for endometriosis, but additionally, they did not find anything major, like they were expecting a lot of adhesions. But the cesarean was like a first-time cesarean in those who had undergone the lymphocyte immunization therapy.
Let us see. The time will tell.
Yeah.
So I think we are coming towards the end of our session. So before we close, we would like to hear from you. What is your take-home message to the listeners? The listeners are both doctors, gynecologists, IVF doctors, as well as family physicians and even patients. So what would you like to say?
Yes, firstly, though, I would really like to thank you, sir and madam, for doing this wonderful job. Yes, but with the help of LIT, I've seen my own patients, those who were unable to get a take-home baby. It did happen. So a big thank to you, sir and madam, and your team, definitely. So take-home message is yes. As I previously only actually spoke out my take-home message, that I want to include these tests in the routine profile. And yes, I do understand and accept that it has got great role in uterine receptivity improvement and definitely immunorejection. So these are the 3 pointers which I'm keeping in my mind and taking my take-home message as. Yes, sir.
Thank you very much. I think you said the crux, what is about reproductive immunology and how it can be beneficial. And I'm sure you have your own center now. Now, IVF doctors, they are known to have their multiple centers. So I'm sure very soon you will also have your next center, maybe little away from Mira Road, and many more in Jaipur, or maybe yes, why not? And wishing you all the best for your future, for your IVF center, and for your work.
Thank you once again, and all the best for the future.
Thank you, ma'am. Thank you. Thanks, sir.
Thanks a lot.